We're on to our last session of the day now. And we have the world's youngest doctor, now a leading ophthalmologist in Utah, Dr. Balamurali Ambati, to whom nothing in life is impossible. This statement he can attest to with his array of achievements, both personally and professionally. If I could request our panel to please step down and make way to accommodate Dr. Balamurali Ambati. He is the professor of ophthalmology and director of cornea research at Moran Eye Center, University of Utah. Dr. Ambati will speak on a doctor's life.
Namaste. Thank you very much for the warm introduction, and let me first thank the Matthew family and the Week for organizing this fantastic event. I've learned a tremendous amount today. I'd also like to thank my esteemed colleagues who have offered their wonderful insights over the course of the day, and I hope that will be helpful to Indian medicine going forward. First, let me strike a note of appreciation to all of my teachers and mentors over the years. It is on their shoulders who I stand. And most importantly, let me thank my family. I'd like to ask my father, who's with me today, to rise. This is Professor Ambati Amrao. Without him, my mother, and my brother, I would not be where I am today. Thank you for the power of your example, your wisdom, and your steadfastness through many challenges. It's my deep honor to be here today and to share my thoughts on some challenges and opportunities, both first in eye care and in medicine as a whole. The eye is the window to the world and also to the soul. It is a wonderful avenue for each of us to see God's creation, but also enables us to see ourselves in another person's. Yet today, 42 million people in the world are denied this privilege, are blind in both eyes. That's the population of Orissa, or half the population of Andhra Pradesh, who cannot see their son or daughter or brother or mother or father. And more than a third of that number, about 15 million people, are blind in both eyes in India. 80% of that number could be prevented or treated. It is needless blindness. In the world, each minute, a child goes blind. And this is not just a sensory disorder. Half of blind children don't make their 5th birthday. This is actually a lethal problem. And in both adults and in children, doing something about this doesn't cost that much money and isn't that hard to do. Cataract surgery can be done in 5 to 10 minutes. In the Indian context, it can be done for $50 or less. It's one of the most life-transforming surgeries that has ever been made. In fact, it was started in India by Sushruta thousands of years ago. Yet the impact of blindness is tremendous. It's about 4 lakh crore per year just in India alone. And the return on investment on cataract surgery or treating pediatric blindness or any number of other blinding conditions is tremendous. Sadly, the importance of vision and eye care just isn't recognized by society at large, government, and the medical profession. And therefore, there are so many 3.5 crore people in the world, 1.5 crore people in India who are needlessly blind. When you look at the causes of blindness, the major plurality is due to cataract, but then you look at refractive error. 20% of blind people could be treated just by having glasses or contact lenses. And then there are things like childhood blindness, a large number of which is simply due to vitamin A deficiency in India and in Africa. Diabetic retinopathy, as one of my previous speakers mentioned, is a small percentage now, but will triple in the next 15 years. So the real problem is, one, when you have a patient like this who comes to us, is taking out her cataract that you can see when you look at her eye is white. That's a very severe advanced cataract. But it's not just taking her cataract out. It's about building a sustainable capacity through education, through awareness and advocacy. Many of these points have been touched on by the previous speakers, and I'd like to show not just the problem, but also things that are working. One of the organizations I'm proud to be associated with is Orbis, which has a flying eye hospital. It landed in India for the first time in 1988, and it focuses just on those aspects I mentioned, building local capacity in eye banking, in pediatric eye care, and advocacy. Outside the United States military, it is the world's only flying hospital. It has a classroom in the front for skills transfer and education, an operating room in the middle of the plane, and a sterilization and recovery room in the back of the plane. It focuses on teaching and skills transfer from ophthalmologists around the world coming in to countries that are in need of education and skills transfer and teaching, not just doing service, but also teaching how to do modern surgery and medical care. The problem of sustainable development is often thought of one as a resource issue, and certainly cost is a big element, but this is just the tip of the iceberg. There are many other things, as all of you know who work in India, underneath the cost issue. So the cost is just the tip of the iceberg, but operation costs, maintenance, administration, logistics, all of these things have to be addressed from a systemic perspective to really advance the cause of sustainable development in medical care. I've heard comments today about how there aren't enough doctors, how there aren't enough doctors in the villages, how there aren't enough resources. And when you consider the numbers, the nation of India has 600,000 physicians. The US has 800,000 physicians for a population that is 1/4 the size. You can't make 4 times or 5 times the number of physicians within 5 years. But you have to look at that from a 30 or 40-year problem and build medical schools, build the investment in medical education to transform that over the course of a generation. And so that requires commitment from the medical profession, from media, from society, from government, from private hospitals, from public hospitals. It's an all hands on deck problem. It's not just a localized problem to one sector. And Orbis, just emphasize what's working. It shows how to deliver care economically. In 1 year, the Orbis organization performed 3 million screenings, half of which were on children, and then a number of free surgeries, over 1 lakh surgeries. The cost per beneficiary was $3, just looking at the people who were benefited in that 1 year. But that falls even more when you look at the skills transfer to the people who were taught and all the people they will help. And it's really concentrated in its efforts in India on childhood blindness. And I mentioned there were 15 million people who are blind in both eyes in India. About 3 lakh of those are children. And that's about 20% of the world's blind children. Half of that number is treatable or preventable. Another 9 million children are visually impaired. They have decreased vision, whether it be from glasses or scarring or something else. And the main causes, when you look at the main causes of pediatric blindness in India, these are easily treatable conditions. Cataract, not having glasses, vitamin A deficiency, measles or rubella, things that can be prevented or eliminated just by vaccination or administration of proper nutrition. So this is not just a medical problem or a sanitation problem. This is a distribution problem of resources like vaccines, vitamins, and so on that could really be fixed within a few years if the commitment was made. As I mentioned, the lifespan is reduced of these children, and the societal potential is reduced, as many of them can't go to school. Orbis, in the last few years, has taken a nation of 5 pediatric centers of excellence to 50. It has made a commitment to the Ministry of Health of India to build 100 more pediatric eye centers within the next 10 years, or actually next 8 years. And it fosters this by education and awareness on a community level, campaigns on a media level, and teaching programs, hands-on training and cyber-site online training, as well as actual flying eye hospital programs. And at this point, I'd like to play my first video. If you can play the first video, it's the YouTube link. Is Himanshu there? In the back? Thanks. So this is just an example of what happens on a flying eye hospital training program, where the plane comes in for a few weeks, and each week there is a session of skills transfer and education from doctor to doctor, nurse to nurse, engineer to engineer, staff to staff, because what we're trying to do is build eye care teams. Can we have the sound?
How old are you? Nine years.
So Zyrene is a 9-year-old girl who had an injury to her eye about 4 years ago. She had a stick to her right eye, and therefore at that time she had a pretty significant trauma where she lost the lens that she was born with. And so what we're going to do today is remove some of the scar tissue that's surrounding the area of injury, as well as put in a new lens. And hopefully that will improve. We'll see a lot better than she is now.
Okay. She was being teased by the children around her. She was playing with, and she was called, "You are blind, blind, you are blind."
Parang hindi na siya pinapansin na kalaro niya. Sinasabihan siya, "Huwag mo natin isali si Bulag. Sana mag-uwi siya sa bahay." Sabi ko, "Bakit na?" Masabi nila,
Being excluded by their playmates to play with her, and again they were calling her name. Why are you, bulag, meaning blind, and excluded from the group. So
masaya to kasi kinatulad nun dati, tinutuso siya. Nakakita siya ng ayos.
she was hoping that she will be able to see, and she will be enjoying her life as a regular girl playing with the playmates.
He works pretty well. Heparin in the bottle, in the infusion, so you can use inoxidil. Everything went well. Everything went according to plan, went really well. Got rid of the scarring and put in the lens. We actually didn't have to stitch in the lens, which was very good. And I think she'll do well. I think she'll do real well. So everything looks fine from the surgery. Her wound is intact, there's no infection, the lens is in good position. Her vision is still not where we want it to be because of swelling from the surgery, and we expect that to improve. We'll see her back on Friday. It should be a lot better. back to the slides. So if we can go back to the PowerPoint. Thank you. So those kinds of experiences really enable physicians and nurses and everyone else involved to light up the lives of children. And this is not just a foreign NGO coming in to do this. Takes a lot of local partnership. And one of the main partners that we've worked with in the past has been Shankar Netralaya in Chennai, which has formed a leading pediatric eye center. And T.S. Sundaran really has been one of the leading ophthalmologists in this regard with respect to India and pediatric ophthalmology. Speaking of Shankar Netralaya, it's a center of excellence in ophthalmology where about half of the cataract surgery performed is totally free of cost. And it's a leading center for training and telemedicine. And telemedicine will play an increasingly useful role as broadband expands into the rural areas to not just take education to rural areas, but also allow rural providers to communicate with centers of excellence on things like glaucoma or diabetes or other problems. And I think this has to be an integral component of delivering healthcare to the villages. No ophthalmology talk in India can be complete without acknowledging the tremendous accomplishments of Aravind Eye Hospital in Madurai, which started in 1977 and now has expanded to 12 other centers in Tamil Nadu. It's the most high-volume center in the world. They perform over 100,000 surgeries each year, 2/3 of which are free. And I think this can be a model that can be scaled up to other fields, where 1/3 of paying patients covers the care of 2/3 of free patients. And I think that needs to be explored in government hospitals and the private sector and so on, how to take the Aravind model and apply that in other areas of medicine. Another thing Aravind has pioneered is not just training, but also manufacturing. They started their own Auro lab 20 years ago to take the cost of intraocular lenses, which are critical for cataract surgery, which cost about $150 in the United States, and they can make them for less than $5 here. And so Auro Lab is now the leading manufacturer of IOLs, not just for India, but Africa and several other emerging economies. And that's enabled Indian ophthalmologists, who are outnumbered, quite frankly, to compete at a cataract surgery rate that is about 1/2 that of the United States. So even though there are only 1 in 10 the number of ophthalmologists in India compared to America, accounting for population, the amount of cataract surgeries done in the US, in India, is about half. That is to say, Indian surgeons are 5 times more efficient, or able to deliver care to 5 times as many people per ophthalmologist, and that's something to be commended and congratulated. LV Prasad is the other leading eye hospital in India, based in Hyderabad, and its main focus is on research, and I think that's something that needs to be considered going forward as well, that medical education should involve not just teaching of the basics, not just clinical care, but also research to develop new cures for the future. And LV Prasad has been very forward-thinking in developing a new model of eye care, where it's not just a center of excellence with eye camps in villages, but they actually develop vision guardians at the base of the pyramid, taking care of 5,000 people in the community. And then they have district-level vision centers for 50,000 people. And then they have secondary care centers for 50,000 in this form of service. And then at the very top, at the apex of the pyramid, is LV Prasad itself, which caters to referrals from a population of 50 million people. And again, this model of extension of excellence from a central hub down into the villages by building those lower layers, I think will be very applicable to other fields in medicine. An emerging institute in the West, I don't want to make this just all about South India, is KKI Institute in Pune, which is very new, less than 10 years old. But in those 10 years, it's performed more than 76,000 free surgeries in Maharashtra. And I'll talk more about them later on in the talk. So the reason I brought all that up is I hope all of you will consider furthering the cause of fighting needless blindness, either by partnering with these or some of the other organizations that are doing great work. And today we've talked a lot about problems. I wanted to talk a little bit about what's been going well and what is going right and how to build on that. Let me now turn to the opportunities and challenges in medicine as a whole. I've been asked to give some comments to young physicians, and I see some young physicians in the back, and the rest of my talk will be directed primarily to physicians and students. First, I'd like to give my hearty congratulations. In a nation with as few resources and as physicians being as outnumbered as you are, Indian physicians are recognized the world over for their skill, ability, and innovation, and are leaders in almost every field. But it is not enough to just celebrate what you have accomplished. As medicine evolves in the coming years, it would be nice to have a crystal ball. I don't have one. But let me take some time to do a few things. Caution you, counsel, and challenge you. There are 4 notes of caution I'd like to strike. First, you're entering medicine in a time of treacherous shoals or rocks. Costs, corporate medicine, and chronic illness are real risks that are going to affect each of us in countless ways. Second, Dr. Kumar pointed out how involved medical education is even in 1920. The exponential growth of knowledge in medicine and technologies will strain memory, stretch attention, and quite frankly overload any person's bandwidth. And that results in the ability to read, write, and think becomes increasingly rare. If a doctor is seeing 100 patients in a day or 150 patients in a day, it's very hard to form a cogent thought. And as such, ideas and vision will become more elusive as insight and consideration and thought become fragmented. And that's something to guard against. Third, be conscious of the demons of desire and despair. Learn to master them so they don't disturb your peace, but yet you can still employ them to affect positive change. Lastly, avoid the twin sirens of greed and self-righteousness, and therefore humility is the best antidote to both. Next, let me share some words of counsel. I'm not much older than the week. The week is 30 today. I'm 35. So I'm probably younger than many of you, but in medicine, I'm something of a dinosaur. I went to medical school before there was internet. I went to residency in PGI before there were cell phones. So my knowledge might be somewhat obsolete, but I hope my experience is of some use in honing judgment. Good judgment is an asset that will keep one out of trouble and help you take necessary and good risks and evaluate opportunity versus hazard. The hard part of judgment is, as Mark Twain said, good judgment comes from experience. Experience, well, that comes from bad judgment. So, of all the skills and qualities that I would ask physicians, future physicians to foster, I would recommend focusing on cultivating 3 in particular: good listening, equanimity, and nimbleness. Good listening is the foundation of almost every facet of your career: building bonds with your patients, learning from colleagues and mentors, being there for staff and residents, and so much more. Any search for truth must begin with the words, "I don't know," and a willingness to listen and learn. When you don't listen, you surround yourself in a bubble, and you fail to appreciate other people, what issues they're coming from, and the importance of their perspective and thoughts. You lose the ability to put yourself in someone else's shoes. And being a good listener is something one has to work on consciously and constantly. It's the basis of what patients are looking for. Doctors care about diagnosis. One has to be a good listener for that. Patients, however, care about prognosis. And you need to understand each patient's needs, perspectives, and values to be their guide and champion in their time of duress. The next trait I'd like to emphasize is equanimity. Sir William Osler deemed this the first among virtues for the physician. No matter the situation, mental calmness affords clarity and steadfastness. The Bible states, "The race is not always to the swift, nor the battle to the strong, neither yet bread to the wise, nor favor to men of skill, for time and chance overtaketh them all." And the Gita, one of the Gita's core precepts, is encapsulated in this verse from Lord Krishna to Arjuna in a moment of doubt and despair. "You must perform the right action, but you are not entitled to the fruits of action. Let no desire of the fruits be your motive, but yet not be attached to inaction." I read this for the first time 12 years ago, and it took me a long time to try to figure out what it meant. I wrestled with the concept. It finally dawned on me that what it means is that in a crisis, you must focus on doing your best to do what is right, but yet be detached from the outcome. It helped me be a better surgeon by helping me concentrate in any moment, in any surgery, on the right thing to do and not worry about the outcome. As a surgeon, I realized how important it is to minimize mistakes and how it is even more important how you react to mistakes. Panic and despair make you lose mental equilibrium, and you make another decision which stacks up and aggregates and makes the situation worse. Sometimes, no matter what you do, the outcome will not be good or what you want, but you have to do your best anyway. And lowering your emotional temperature, mastering your emotions in these tough situations is key to slowing down your thought, enhancing your perception and analysis, and permitting clarity to dispel clouded thinking. Pressing for a solution when none is apparent can sometimes be the wrong thing to do. Picking up a scalpel and cutting when you don't understand the whole picture can cause more problems. So the good surgeon is defined not by just technical dexterity or superior hand-eye coordination, but by sound decision-making and sound judgment that is fused with clarity and effectiveness. Equanimity is also about righting yourself in a hard time. If the present is dim or bitter and the future seems cold or barren, sometimes it's tempting to forfeit hope and forget that your life is integral in the universe's tapestry. And I try to remember two things in that situation. If something is really bad, it could always be worse. And if it can't, then it can only get better. So be grateful for your blessings, health, home, friends, faith. And while others can take many things away from you, there are some things that can't be taken away. What you learn, your personal honor, and the satisfaction of service, those things can never be taken away by anyone else. And the third quality I wanted to emphasize was nimbleness. And this encapsulates several qualities: resilience, courage, flexibility, versatility. When Pandora opened her box of the world's evils, many bad things came out, but the last thing that came out was hope. And sometimes hope or memory can feel like a prison, but in reality, hope is the root of change. George Bernard Shaw, the famous playwright, wrote, "The reasonable man tries to adapt to the world. The unreasonable man tries to make the world adapt to him. Therefore, all progress depends on the unreasonable man." Success, therefore, lies in effort as much as in result. And the need for struggle is not grounds for avoidance. As Bruce Wayne's father said in Batman Begins, "Why do we fall? So that we can learn to pick ourselves up." And to tack on to that, as my father always told me, persistence and perseverance always pay off in the end. And what gives you the strength to do these things is both courage. Just as importantly, if you're just good at one thing, you're very vulnerable. If you become so focused that you are the ultimate expert at one thing, then could your job be automated by a robot, or insourced or outsourced? By being versatile and multi-talented, one differentiates oneself and lays a foundation for independence and security for years to come. And most importantly, when you make your mind more open to learning new things in the future, the more experience and learn you can absorb to help your patients. And therefore, nimbleness is what confers joy, recoverability from a mistake, the ability to think broadly from other perspectives, and the ability to persist and roll with the punches while holding fast to your principles, and the ability to take doubt and to use it to find new knowledge and find faith. When in doubt about challenging situations, these are 4 personal principles of mine. Promises are made to be kept, most important. Rules are made to be bent. Records are made to be broken. And schedules are made to be changed. So in my own life, I've found these 4 principles pretty much cover most challenging situations, and hopefully they might be of some use to you. So think ahead. When you fail to plan, you plan to fail. And along that notion, I'd like to share another of my father's sayings: struggle now and enjoy later, or enjoy now and suffer later. And then in challenging situations, truly difficult choices regarding a patient or someone else, I ask yourself to think of 3 questions. First, is it good for the patient? Second, is it good for the profession? And then, if the answer to both those questions, is it good for the patient and is it good for the profession, then if the answer to both is yes, and only then, ask yourself, is it good for me? As long as you put those 2 principles ahead of your own personal, what's in it for me, in general, you'll make the right choice. And last bit of advice or counsel: value your time. Guard it jealously from fools and irritants, yet be generous with it to your families, your trainees, and community. So I've sounded caution and I've offered counsel. Let me now throw down some challenges to you. First challenge: get involved. For too long, physicians have been mere objects in healthcare battles. Perhaps it is time to become involved in politics to enable better organization of medical care and direct delivery of medicine as opposed to corporations or insurance companies. After all, neither politicians nor insurance companies nor hospitals take the Hippocratic Oath. Physicians need to promote education and awareness among the public about medical issues. And in that vein, I would urge you, do not follow America's mistakes and let government, insurance companies, lawyers, or drug companies get in between doctors and patients. Cultivate a focus on trying to keep people healthy and preventing problems, as well as on treating problems, so that future physicians are more likely to focus on primary care. That's been a big focus of today. I would offer a simple idea. Perhaps physicians could set aside 1% of their income so that medical students don't have to accumulate debt. And in exchange, future medical graduates could, in exchange for not having debt, could serve 1, 2, or 3 years in the villages. It sounds like something that may not take, but I think if enough people signed on board, I think you would spark great interest and get the ball rolling. As has been pointed out, 80% of the physicians are in the cities, whereas 80% of the population is in the villages, or something like that. And how better to encourage getting the physicians to the patients than by supporting primary care. And Australia is a great example of that. The Australian system really focuses on enabling physicians to emerge debt-free and at the same time go to the rural parts of the country to serve. Another thing in medical education has to be building of centers of excellence. I mentioned a few in ophthalmology, but I think it's high time that the private hospitals, government, and medical colleges partner to build multiple centers of excellence to focus on building the next generation of physicians who can do teaching, training, research, and clinical care. To young physicians, when you're in medical school or residency, while you're in training, your path is clear. You have landmarks of applications, tests, certifications, which are well defined. But once you are done, the road becomes hazy. You have to figure out what you want your own milestones to be. And will your primary goal be the personal maximization of wealth? I'm going to put that question right on the table. There's nothing wrong with that. You all have a right to make money. But take a moment to consider, what is medicine to you? Is it just a 9-to-5 job? Is it a career? Is it a calling? If it's a job, you will make a living, and over time, just coast with the least amount of effort to make the most amount of money. If that's what you want, fine. But I hope your professors have not spent the better part of their life teaching body mechanics. While managing the business of medicine is important, letting medicine become only a business corrodes our soul. The next option was a career. And if you view medicine simply as a career, then you will set down several goals: papers, ranks, awards, building a practice, and you will probably and hopefully achieve them. But if medicine is more than just a job and more than just a career, then it really becomes a part of you. It becomes a calling, an integral part of how you fulfill yourself. And that's not about rank, awards, or about money. It's not about rupees earned or goals achieved. The original meaning of the word doctor is twofold: one who makes things better and one who teaches. And so, how will you make things better? How will you make a difference? And I think it's about service, doing things beyond the remit of obligation or the purview of compensation or remuneration, things that you are not replaced for easily, things like research and teaching and public health and overseas work. At this point, I'd like to show my second video, if you could pull that up, please. This video is about KKI Institute, which I mentioned before. If you can switch to the second video. Thank you. Stevens-Johnson syndrome, which is a skin and eye condition. So he lost his vision, and he lost his other eye from a playing accident as well. To leave school.
We are glad to know that our child has got admitted over here and has been chosen from your side for cornea transplant. I am very happy for it.
Okay, there is an 11-year-old child who has a history of accidental trauma where he's lost his right arm. Now his left eye is very scarred. He has complete corneal opacification and significant neovascularization. He would be at very high risk for rejection for a corneal transplant, and in addition there's near impossibility of getting age-appropriate donor tissue for him in India. So what we're planning to do is a Boston keratoprosthesis, an artificial cornea, where we will remove his cornea and his lens and put in a new lens and an artificial cornea. And that's the plan for today. This part actually shows some scenes from the surgery, so if anyone gets upset, feel free to close your eyes. Have the lights up and thank you. We can stop the video. We can stop. Thank you. So thank you for the time that I've had with you today to conclude I'd like to share one last quote, also from Mark Twain. There are three types of people in this world: those who make things happen, those who watch things happen, and those who don't know what happened. To be worthy to suffer, to be worthy to serve the suffering, let's all try to be of the first kind. Thank you. Dhanyawad.
Thank you very much, ladies and gentlemen. This has been an amazing experience having Dr. Balamurali Ambati here to speak on a doctor's life. May I request Mr. Varghese Chandi to please come up and present a small little token to him. Okay. He's here, he's here, he's here. Right there. Would you like to take on any questions now? Okay. So if there are any questions, you can make it very short. Just, can we give opportunities to others if there are any? Okay, I'll just give you my mic.
Doctor, one question. You mentioned 65,000 free surgeries, eye surgeries. How do you fund those 65,000 free surgeries?
Sure. So that 65,000 was just that one hospital, and their model is very similar to the Aravind model, where about 1/3 of the patients are paying patients, and so there's financial assessment, and based on the ability to pay, those patients would pay full price, and then the other 2/3 of patients are essentially free.
Besides innovation, the biggest challenge in medical science is diffusion of innovation. As in India, you have one AIMS and no other AIMS. All would be AIMS-like. Similarly, in medical science, it is time and again been shown that diffusion of innovation is almost not there, or if it is there, it's slow, precarious. By that time, technology changes. Some insight into that?
So, my patients in the US ask me how long it takes to do a cataract surgery. And they're expecting to hear 10 minutes or 8 minutes or 12 minutes. But in reality, it takes, after high school, 4 years of university, 4 years of medical school, 4 years of residency, and all the other training of one's teachers. So that's exactly why innovation takes a long time to diffuse, is the sheer amount of time and training it takes to put into one person to make them qualified to cut on another person's eye or whatever other field of medicine they're in. So we actually don't want innovation to spread too quickly, right? Because not every new drug is good, not every new surgical technique is good. And so that period of validation and testing intrinsically takes time. But the part of diffusion of knowledge that's bad, if you will, once innovation has been proved, why does it take so long for the general practitioner to employ a new drug or technique? That part can be shortened. That part can be shortened by what Dr. Kumar brought up today in terms of broadband education electronically. That would be not just for medical education in medical school, but also for continuing medical education. Wouldn't you agree? In terms of CME. And then things like what Orbis does, bringing in physicians from around the world to transfer new skills. And so I think those kinds of efforts are being done, but it just requires resources to expand the bandwidth, if you will, to transmit that knowledge. I hope that answered your question. I know Dr. Kumar, you wanted to say something.
Spreading this innovation. And we've recruited Cornell, Columbia, Stanford, Stony Brook, Tufts, Northwestern, and Rush, all of whom are now going to be trained to do the things that they found innovative. And the AMA felt it was important enough to give money for it.
And perhaps a similar program could be started in India, where AIMS or other leading centers could drive that kind of diffusion.
Doctor, along with your quote on humility, I would also like to quote what the father of our nation said. This is something which you should learn, given by an elder brother to a younger brother. An eye for an eye makes the whole world blind.
Absolutely.
Vijay, you had a question?
First of all, a beautiful presentation.
Thank you.
Heartwarming, really.
Thank you.
My questions are specific to this Kedar case that you presented.
Yes.
You said a lot many children were seen and this boy selected. I would like to know what were the criteria for selecting this boy and whether this cornea made in Boston, whether that is what you call a bionic eye. And also at the end of 4 hours, you've said it was a success. Does it mean that you took off the dressing at the end of 4 hours and he could walk? Please.
Sure. So, first question was, how did we choose what to do? So, most of these trips that I do, I try to do 2 or 3 weeks of international work a year. The first day, Monday, is screening day. And so that particular Monday, I think we saw 100 patients, 30 were children. And it was very sad seeing child after child that we could not do anything for. The most common thing we saw was measles keratitis, or measles infection of the cornea, that had destroyed their cornea when they were 2 or 3 years old. And by the time they came to see me, they were 7 or 8 years old, and the damage was done. There was not anything that could be done for the vast majority of those children, sadly. You saw in the video there were 3 boys who we worked on, and so each of those 3 had conditions that were treatable, and we had the resources to treat those boys. Basically, it came down to, is the condition fixable, and can what we have be used effectively to make a difference? And that was the decision making. As far as the second part in terms of is the Boston keratoprosthesis available in India, I don't believe it is at this point. I believe Dr. Dolman, who's the founder of the keratoprosthesis, is in talks with a company called Priya to employ it in Mumbai. Maybe Rajat, you might have more insight into that, but I believe it either will be soon or soon available here for manufacturing at a much lower price. In that particular case, the device was donated, so there was no price on that surgery. And then as far as how fast was the recovery, it's not getting off the table and life is grand. It takes actually a lifetime of eye drops afterward to prevent infection of the artificial cornea. As far as the visual recovery, I believe within 2 or 3 weeks he was seeing pretty well. That's what I'm told. He went back to normal school and regained functionality. As far as the bionic eye, I'm going to not steal Rajat's thunder. I'm sure he'll tell you more about it, but this is just an artificial cornea. It's just the front of the eye.
Thank you very much, ladies and gentlemen.
There's one more.
Oh, okay. We'll accommodate one more.
Many congratulations, and it was a very inspirational talk, very philosophical. I'm Dr. Kim Maman. I'm a urologist and Associate Director of Christian Medical College, Ludhiana. I think you have used your entire career to give back to your country what you have earned over the last many years. And I hope many of the US citizens of Indian origin will take cues from you, and you would be a motivating factor for them to return back to their motherland, because India has been a major exporter of doctors to the United States and many European countries. And I'm really impressed and encouraged by your talk and your witness of giving back to the country for the very needy patients of this country. Thank you very much.
Thank you.
Thank you very much. You really echo a lot of our sentiments as we have been hearing Dr. Ambati. Ladies and gentlemen, although we've come to the end of today's proceedings, I know the celebrations will continue, so we have dinner for you at 7:30. just outside this very hall. Please join us for dinner at that point. We will begin tomorrow at 10 a.m. and we have a whole day of listening to more doctors and perhaps being more inspired by them. Thank you very much.
Somebody can keep it here. We'll see tomorrow.